Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text.
Imagine a patient walks into your urgent care clinic. He is a young guy, early 20s, and he is holding his arm.
Okay, setting the scene. I like it.
Yeah, and he has got this massive gaping laceration across his forearm from a landscaping accident.
Ouch. Yeah, we see those all the time.
Right. So your immediate instinct, which is basically drilled into you from day one of nursing school, is to reach for the sterile, normal saline.
Oh, absolutely.
You want a perfectly pristine, completely sterile environment to wash out that wound. But what if the data told you that the absolute best tool for the job isn't sitting in a sterile plastic bottle on your supply cart, but is actually, the tap water running right out of the sink in the exam room?
It sounds completely counterintuitive, doesn't it? I mean, it goes against literally every sterile technique principle you have ever memorized.
It really does. It feels wrong.
It feels so wrong. But, when you actually break down the physics of wound irrigation and the pathophysiology of bacterial colonization, reaching for the tap water suddenly makes perfect evidence-based sense. And that tension between what feels instinctively right and what the clinical evidence actually demands, that is exactly where we are going to live today.
And that is exactly why we are here. So welcome to our deep dive. Consider this your highly supportive one-on-one tutoring session.
Grab a seat at the table with us.
Exactly. We are the Last Minute Lecture team, and our specific mission today is to prepare you, the advanced practice nursing student, the future NP, for the incredibly fast-paced, high-stakes environment of urgent care and primary care trauma.
It is a wild environment.
It is. We are taking all the crucial, dense material from Chapter 75 on common injuries, and we are breaking it down. Because, let's be real about the clinic floor here, you are basically playing diagnostic minesweeper.
That is the perfect analogy.
Right. Like you walk into room 3, and the board might just say headache or scraped knee, but you genuinely never know if you are dealing with a simple tension headache or a life-threatening subdural hematoma that is just, masquerading as a mild concussion.
Yeah, diagnostic minesweeper is exactly what it is. Clinicals are overwhelming. Board prep is completely overwhelming.
Tell me about it.
But what separates a competent clinician from a truly exceptional one isn't just the ability to memorize a list of algorithmic treatments.
Right. Anyone can memorize an algorithm.
Exactly. It is the ability to recognize subtle patterns. It is deeply understanding the underlying pathophysiology behind the symptoms you are seeing.
Yeah.
I mean, when you understand why the tissue is reacting a certain way or how a specific mechanism of injury transfers energy into the body, the treatment plan isn't something you have to blindly remember. It just logically follows.
It makes sense. It just clicks. So, we are going to distill these textbook pages into digestible, clinically applicable pearls that you can actually use when you are standing right there at the bedside.
I love it. Let's do it.
And to start, we are going to look at the absolute front line of urgent care. We are talking about the body's primary armor, right? The barrier that keeps the outside world out until it violently doesn't.
Wounds and lacerations.
Wounds and lacerations.
This is the absolute bread and butter of acute care. But I want to caution you right out of the gate, do not let the sheer frequency of these visits lull you into a false sense of security.
Oh, for sure. It's easy to get complacent.
It is. But wound management accounts for an incredibly significant percentage of malpractice claims against advanced practice providers.
Really? That high?
Yes. The margins for error, particularly regarding retained foreign bodies or missed nerve damage, are razor thin. You have to be meticulous from the absolute moment you walk into the room.
Okay, so let's start by painting a picture of who is actually sitting on your exam table. The epidemiology tells an interesting story here. The data shows that almost 75% of patients presenting with traumatic wounds are men.
Yep.
And the average age sits right there in the early 20s.
Classic.
Right. But what really jumped out at me from the data was the infection rate. Wounds in adults become infected about 5% of the time. But in pediatric patients,
so much lower.
It drops dramatically to only 1.2% of the time.
That statistical difference is striking. And, it should immediately inform your clinical reasoning.
How so?
Well, it speaks to the incredibly robust, highly vascularized healing capacity of pediatric patients. But it also highlights the mechanisms of injury and the critical comorbidities we see in the adult population.
Okay, that makes sense.
Like if you are evaluating a healthy 7-year-old with a laceration, your baseline anxiety about infection is going to be pretty low.
Right, they bounce back from everything.
Exactly.
Yeah.
But if you have a 65-year-old adult sitting there with, say, poorly controlled type 2 diabetes or peripheral vascular disease, that 5% baseline risk, it can climb exponentially.
Wow, yeah.
This is exactly why your subjective history taking is your absolute first line of defense.
Yeah.
You need to investigate the mechanism of injury, the exact age of the wound, their tetanus immunization status, and those crucial systemic comorbidities.
Because the mechanism tells you the story of energy transfer, right? Like a paper cut or a slice from a kitchen knife is a low energy injury. It cleanly separates tissue.
Yes.
But a crush injury from a car door or a tear from industrial machinery, that is massive kinetic energy transfer.
Massive. And that results in widespread cellular death and microvascular thrombosis, even if the surface of the wound doesn't actually look all that enormous.
And to really understand what that energy does, we have to talk about the pathophysiology of the skin itself. I mean, it is not just a wrapper holding our insides together.
Oh, far from it. The skin is a highly dynamic, vital, functional organ.
Yeah.
You have the epidermis on the outside and the much thicker dermis sitting beneath it.
Right.
It regulates our core temperature. It prevents massive fluid loss and dehydration. It houses the intricate network of cutaneous nerves, and it synthesizes vitamin D.
It's busy.
Very busy. But the most crucial concept for you to grasp regarding wound healing, and particularly for managing your patient's expectations regarding permanent scarring, comes down to understanding cellular depth.
This is a phenomenal pearl for both your board exams and for sitting face-to-face with an anxious patient. If a wound does not penetrate down to the stratum germinativum,
And that's the deepest basal layer of the epidermis.
right, if it doesn't penetrate that layer, it will not leave a scar.
Precisely. The stratum germinativum is basically the cellular factory. It is where the regenerative magic of the skin happens.
Okay.
If that specific basement layer remains intact, the epidermis can completely regenerate itself with identical tissue. It's flawless.
Oh, wow.
But the moment an injury breaches that layer and dives into the dermis beneath it, the body's primary goal shifts. It goes from perfect regeneration to rapid repair.
It just wants to close the hole.
Exactly.
Yes.
It has to patch the structural defect with collagen, and collagen formation, by definition, means a scar.
So let's actually look at how that biological patch job happens. Wound healing is broken down into 4 simultaneous, highly choreographed phases. I initially thought of it like a construction site, but honestly, reading this, it's more like a military response followed by a massive civil engineering project.
That's a very accurate way to conceptualize it. So phase 1 is the injury or coagulation phase. This is the immediate emergency response.
The sirens are going off.
Right. The exact second the tissue is disrupted and blood vessels are torn, the coagulation cascade begins. Platelets aggregate at the site.
To plug the hole.
Yes, but these platelets aren't just forming a physical plug to stop the bleeding. They are active biological messengers.
Oh, really?
Yeah, they degranulate and release chemotactic factors that literally ring the chemical alarm, signaling the immune system and enhancing the inflammatory response.
Which brings the heavy machinery to the site. So that's phase 2, the inflammatory phase.
Right. In response to those platelet signals, local capillary permeability massively increases. The blood vessels become leaky.
And this is why the local area gets red and hot.
Exactly. It becomes erythematous, warm, and swollen, the classic signs of inflammation. And this leakiness is totally intentional. It allows white blood cells, specifically the early arriving neutrophils and the later arising monocytes, to easily migrate out of the bloodstream and into the wound bed.
Okay, so the neutrophils act as the initial demolition and cleanup crew, right? Aggressively scavenging debris and destroying invading bacteria.
You got it. But the monocytes, which mature into macrophages in the tissue, they are really the site foreman.
They're running the show.
They absolutely are. Macrophages continue the cleanup, but they also secrete vital growth factors. They act as the project managers, stimulating fibroblast replication and driving neovascularization.
Which is the literal building of a new capillary network to feed the repairing tissue.
Yes. Without macrophages, the entire healing process stalls completely.
Okay, so the site is secure, it's sterilized by the neutrophils and cleared of debris. Phase 3 is epithelialization, and this happens incredibly fast, right?
Very fast. Cells at the wound edges literally flatten out and migrate across the surface of the defect to meet in the middle.
Like reaching across a canyon.
Exactly. If you are dealing with a clean surgical incision or laceration where you have perfectly approximated the edges, meaning you brought them together with sutures, that wound will be completely epithelialized and sealed from outside bacteria within 24 to 48 hours.
Wow, 2 days and it's sealed. And we call that specific process healing by primary intention. You, the clinician, have mechanically closed the gap.
Right. But if the wound is too contaminated or too large or has massive tissue loss, it must be left open.
And then what?
It then has to heal from the bottom up, slowly filling the defect with red BC granulation tissue.
Okay, healing by secondary intention.
Exactly. And it is a much slower, more resource-intensive process for the body.
Now, here is where the clinical timeline gets really fascinating, especially when you are doing follow-up care. The final phase is the remodeling phase. This involves deep tissue formation and wound contraction. It starts around day 3, but it can continue for up to 6 months, sometimes even a year.
Yeah, this is where we have to discuss the concept of tensile strength. This is an absolutely vital physiological metric for you to understand as a student.
Why is it so important?
It dictates when you decide to take sutures out and exactly what you tell the patient about when they can return to work or sports.
Okay, so tell me about the timeline.
So the fibroblasts are laying down collagen. Collagen synthesis actually peaks rapidly right around day 7. But, and this is a massive caveat that surprises a lot of students, at 3 weeks post-injury, that newly healed wound only has 15 to 20% of the tensile strength of normal uninjured skin.
That is wild to think about, only 20% strength at 3 weeks.
Yep.
So the patient looks at their arm, the skin looks completely healed, the scab is gone, they feel fine, but that internal tissue architecture is still incredibly fragile.
Extremely fragile.
If they go back to, lifting heavy boxes at work, they could easily rip that wound wide open.
Exactly. The collagen fibers are initially laid down haphazardly. During the remodeling phase, those fibers are slowly broken down and reorganized into a more structured, cross-linked pattern along the lines of physical tension.
But even by 4 months, the tissue only reaches about 60% of its original strength.
Right. It rarely, if ever, returns to 100%.
Oh.
And this incredibly slow remodeling process is exactly why you will see plastic surgeons refuse to perform a scar revision until at least 6 months have passed.
Because it's still changing.
The tissue is literally still shifting, changing, and contracting during that entire half-year period. You can't fix a moving target.
That makes perfect sense. So keeping that deep pathophysiology in mind, let's step into the exam room. You have your patient. You are starting your objective exam. First, unbreakable rule, and listen closely to this one. Before you do anything else, before you irrigate, before you even look at your needle to draw up local anesthesia, you must comprehensively check distal circulation and sensation.
I cannot emphasize this protocol enough. It is the absolute bedrock of safe practice.
Right.
Think about the pharmacology of lidocaine. When you inject it, you chemically block nerve conduction. You completely numb the area.
That's the whole point.
Right. But if you fail to document that the patient had perfectly intact 2-point discrimination and full motor function before you numb them, and then 2 days later they present with a numb finger or a dropped wrist,
Oh, no.
you are completely blind. You have no medical or legal way of knowing if the original traumatic injury severed the nerve or if the tip of your needle accidentally caused iatrogenic damage during the injection.
You are immediately in diagnostic muddy waters, and the liability is entirely on you.
100%.
So you systematically check the pulses distal to the wound. You check capillary refill in the nail beds, and normal is brisk, less than 2 seconds. You perform a gross neurological screening. Have them move their fingers against resistance. Compare sensation bilaterally.
Yes.
Only after you have charted that baseline do you reach for the anesthetic.
And once the tissue is properly anesthetized, you need 2 things. A very bright overhead procedure light and a completely bloodless field. You cannot assess what you cannot see.
Definitely.
You have to aggressively explore the entire depth and the full anatomical length of the wound. You use your instruments, like adze and forceps with teeth, to gently lift and retract the wound edges.
But there's a vital safety pearl here, right?
Yes, a big one. Do not blindly probe down into a deep wound tract with hard metal instruments like a hemostat.
Because if you can't see the bottom, dragging metal through blind tissue is a great way to accidentally puncture an unseen artery or shred an intact nerve.
Exactly. Whenever possible, probe the depth of a wound gently with a gloved finger instead.
And when we are looking down into that wound bed, we are hunting for the shiny white structures.
Right. Color is everything.
Adipose tissue is yellow and bubbly. Muscle is deep red and striated. But an exposed tendon, that looks like a taut, shiny white cord.
It really does.
The joint capsule underneath is also a distinct, shiny, white, fibrous structure. If you see those gleaming white tissues at the base of your laceration, the complexity of your patient's injury just skyrocketed.
It changes the whole game.
Yeah.
So let's apply this directly to the clinical presentations you're going to see. We need to dissect the different types of wounds because your approach changes drastically.
Let's start with abrasions.
Okay, abrasions. These are partial thickness defects, usually caused by a harsh, scraping friction force against a rough surface. Think of classic road rash from a motorcycle laydown, or a bad slide on a gravel track.
The physiological risk here isn't necessarily a deep space infection, right? The massive risk is tattooing.
Yes, traumatic tattooing.
When a patient grinds their skin into asphalt, tiny particles of dirt, gravel, and grease are driven deeply into the dermal layer. If you, the provider, do not painstakingly scrub out every single microscopic piece of debris, the epidermis will eventually epithelialize right over the top of it.
It seals it in.
You will trap the dirt permanently under the skin, leaving the patient with a dark, permanent traumatic tattoo.
Which means treating a severe abrasion isn't just a gentle wipe with a gauze pad. It requires vigorous, painful scrubbing, often with a surgical sponge or a soft brush.
And because that hurts immensely, it necessitates excellent anesthesia.
For large abrasions where injecting lidocaine hundreds of times just isn't feasible, topical anesthetics are heavily utilized. Viscous lidocaine applied directly to the raw tissue is standard.
But here is the critical physiological warning for you as an NP student. You must use extreme caution with pediatric patients.
Because of the surface area to body mass ratio.
Right. Children have a much higher surface area relative to their weight. If you slather a large volume of high-concentration topical lidocaine over a massive denuded road rash on a small child, that drug has direct, unhindered access to the systemic circulation.
It bypasses the intact skin barrier entirely.
Completely. The capillary beds in that raw tissue will absorb the lidocaine rapidly. This can lead to rapid systemic lidocaine toxicity, presenting a central nervous system excitation, seizures, and eventually cardiovascular collapse.
It's terrifying. You must calculate the maximum safe dose by weight, apply it sparingly, and importantly, you have to wait.
Right. Give it time to work.
Give it 10 to 15 minutes to fully absorb and block the nerve endings before you start scrubbing.
Okay, moving from wide scrapes to messy tears. Stellate or flap lacerations. These are those awful, jagged, star-shaped rips. They almost always happen when blunt force trauma crushes the skin against an underlying bone, like a patient who falls forward and smashes their chin or their forehead on the edge of a table.
The skin basically bursts open under the pressure.
The clinical trap with a flap laceration is that the worst of the damage is usually hiding. You cannot just look at the surface.
No, you must actively lift and fully retract the tissue flap to visualize the deep base of the wound. The most severe tissue avulsion and the deepest bleeding vessels are almost always tucked underneath that flap.
And if this injury occurs on the scalp, which is highly common, your primary objective is to evaluate the glia aponeurotica.
Yes, the glia is that incredibly tough, dense layer of fibrous connective tissue that covers the upper part of the cranium, sitting right above the periostome of the skull.
The glia acts as the major structural anchor for the muscles at the forehead and the scalp. If your patient has a laceration that slices through that fibrous glia, creating a defect larger than roughly 3 centimeters, you cannot simply staple the superficial skin closed and call it a day.
You cannot. You, the clinician, must perform a layered closure. You have to use absorbable deep sutures to carefully reapproximate and tie the edges of the glia back together before you ever address the skin.
If you miss that and you just staple the skin over a gaping hole in the glia, the underlying occipiter frontalis muscle can literally herniate through the defect.
Oh, it's bad.
Furthermore, the subgaleal space is highly vascular. If it's left open, a massive spreading hematoma can form, tracking all the way down to their eyes. It's a disaster.
Complete disaster.
Now, what about the opposite of a jagged tear? Linear lacerations. Clean, straight cuts, like from a kitchen knife or a piece of glass.
Well, your management options here are much broader, and your decision is largely dictated by the physical tension on the skin edges.
Okay, let's talk about tension.
For a linear laceration on the scalp, where the cosmetic outcome of a tiny scar is negligible because it's hidden by hair surgical staples, are phenomenal.
They're so fast.
Incredibly fast to place, they hold securely, and because they are non-reactive stainless steel, they often cause a much smaller local inflammatory tissue response compared to braided sutures.
Nice.
And if you have a clean, very low-tension wound on the arm or the face, and importantly, a wound that does not cross over a joint space, tissue adhesive like liquid skin glue is a fantastic modern option.
The literature on tissue adhesive is really compelling. It's remarkably fast, it spares the patient the pain of needle pokes, and multiple studies show that the long-term cosmetic results on low-tension wounds are completely equal to, or sometimes even better than, traditional meticulous suturing.
However, the physics changes the moment you encounter a high-tension wound. If a laceration is located over an actively moving joint, like the elbow or the knee, or on the chin where the skin pulls tightly, skin glue will simply fail.
It'll just pop right open.
The mechanical forces will rip it apart. Those high-tension areas strictly require deep, subcutaneous stitches to physically pull the tissue together and absorb the tension from the inside.
Right.
Followed by specialized epidermal sutures, like vertical or horizontal mattress sutures, to heavily reinforce the superficial skin edges. This specific technique dramatically reduces the risk of dehiscence, which is the nightmare scenario where a closed wound forcefully pulls itself back open days later.
Ooh, nobody wants that. Let's go back to those shiny white cords we mentioned earlier, the tendons. You are exploring a deep cut on a hand. You see the tendon. You have to functionally test it. You can't just ask them to move their finger. You have to test their range of motion against active resistance.
This is so crucial.
Have them try to open or close their hand while you physically push back against their fingers. If they experience sharp focal pain with that resisted movement, even if they have full range of motion, you have to suspect a partial tendon laceration.
And this is where scope of practice and referral pathways become critical for the NP. Let's establish a firm rule of thumb based on anatomy. Extensor tendons are the long, relatively simple cords on the dorsal aspect, or the back of the hand. They function to open the fingers.
Right.
If a patient has an extensor tendon laceration, advanced practice providers, depending on their specific procedural training, their comfort level, and the protocols of their facility, can often safely repair those with specialized suturing techniques.
But flexor tendons, the complex anatomical system on the volar or palm side of the hand and fingers, that is a completely different universe.
It is an absolute do-not-touch scenario in the urgent care setting.
Really? Hands off completely?
Completely. Flexor tendons carry an astronomical risk of morbidity. They run through an incredibly intricate, tightly tolerant system of fibrous sheaths and biological pulleys.
It's like a complex machine in there.
Exactly. If you attempt a primary repair of a flexor tendon, and your knot is slightly too bulky, or the tension is infinitesimally off, the tendon will catch in the pulley sheaths. It will not glide.
Wow.
A failed or poor repair results in a permanently contracted, functionally useless finger. Flexor tendon injuries require precise primary microsurgical closure by a dedicated hand surgeon or an orthopedic specialist in an operating room.
What about joint spaces? Let's say a patient slips while working in the garage and takes a deep, penetrating stab wound from a screwdriver right near their patella. You are looking in the wound, and you honestly aren't sure if the tip of the tool penetrated through the tough, fibrous joint capsule and actually entered the sterile knee joint.
You cannot operate on a wait-and-see approach here. You most definitively rule it out.
Why is it such a big deal?
Because the synovial fluid inside a joint space is an incredibly rich, avascular medium for bacterial growth. If bacteria from that screwdriver seed into the joint, a septic joint will develop rapidly.
And that's bad news.
The inflammatory response and the bacterial enzymes will literally dissolve and destroy the hyaline cartilage of the knee within a matter of days. It is irreversible destruction. If you cannot visually confirm that the shiny white joint capsule is completely intact, you must perform a diagnostic saline load test.
Okay, this saline load test sounds both primitive and incredibly effective. Walk us through exactly how you do this test on a knee.
All right, so you prep the area under strict sterile technique. You find an entry point completely separate from the traumatic wound, usually a standard arthrocentesis approach on the lateral side of the patella.
Okay.
You insert a large bore needle directly into the joint space. Then, using a large syringe, you forcefully inject sterile normal saline directly into the joint cavity. For a large joint like an adult knee, you need a substantial volume. Typically 150 to 200 milliliters of fluid.
You literally pump the closed joint full of fluid until it is bursting with pressure.
Exactly. You intentionally overpressurize the joint capsule from the inside. While you are injecting, you closely observe the original traumatic wound.
Watching for a leak.
Yes, if the capsule is violated, the fluid will find the path of least resistance. You will see the clear saline actively leaking or squirting out through the stab wound. If you see that leakage, the capsule is definitively breached. You immediately consult orthopedics for a surgical washout.
And speaking of joints, we have to highlight the knuckles, the metacarpophalangeal, or MCP joints. If a patient comes in with a small, innocent-looking laceration right over their knuckle, and there's even a remote theoretical chance that the cut was caused by their fist forcefully striking another human being's mouth.
Yes, that is the infamous fight bite. It is arguably the most deceptive and dangerous wound in primary care. We will dissect the exact microbiology of human bites shortly, but anatomically, a fight bite over the knuckle is an automatic immediate orthopedic emergency.
Because it hits the joint.
It requires extensive surgical irrigation, often in the OR, because the tooth almost always penetrates the joint capsule.
Which brings us perfectly to the consequence of these untreated exposures: infections. Let's talk about cellulitis and abscesses. A patient presents 3 days after a scrape with spreading erythema, localized warmth, and painful swelling. Standard cellulitis.
Right. Beyond prescribing the correct empiric antibiotics to cover common skin flora like streptococcus, the most crucial assessment and communication tool you have in the room for cellulitis is astonishingly simple. A medical tissue marker or just a standard pen?
A pen.
Yes. You must physically trace and outline the leading visible border of the red erythema on their skin.
It seems so basic, but it is brilliant, because when that patient returns for their 24 or 48-hour follow-up check, you aren't relying on their subjective memory of, I think it looks a little better, or your own fuzzy recollection.
Exactly. You have hard, definitive, objective border. If the red angrily extends 2 inches past your ink line, your oral antibiotics are failing, the infection is advancing, and you likely need to escalate to IV therapy.
Now, if that localized infection walls itself off into a distinct fluctuant collection of pus and abscess, your treatment paradigm shifts entirely. The vast majority of community-acquired skin abscesses today are driven by Staphylococcus aureus, and specifically, we must assume methicillin-resistant Staph aureus, or MRSA, until proven otherwise.
Yes, assume MRSA.
Here is the physiological truth. Throwing oral antibiotics at a mature, fluctuant abscess is largely futile.
Because the antibiotics simply cannot penetrate the fibrous wall the body builds around the pus. It's a physical barricade.
Precisely. You have to physically breach the wall. You must perform an incision and drainage, an I&D, to mechanically evacuate that massive bacterial load. If you leave that pressurized cavity of necrotic tissue and millions of multiplying bacteria intact, it will eventually rupture, potentially deep into the fascial planes, leading to severe systemic bacteremia.
Here is a fascinating, highly practical clinical pearl regarding the administration of local anesthesia prior to performing an I&D.
Let's hear it.
When you are numbing the area, you inject the lidocaine superficially, directly into the roof of the abscess, right where you plan to make your incision, and then ring it around the circumference of the surrounding healthy skin.
Yes, and the crucial negative instruction here is, do not plunge your needle deep and inject anesthetic directly down into the purulent cavity itself.
Do not do it. First, mechanically, injecting more fluid into an already tightly pressurized, painfully swollen sac increases the pressure and the patient's pain exponentially.
That sounds awful.
It is. But more importantly, from a pharmacological perspective, it simply does not work.
Because of the chemistry, right?
It is pure chemistry. The environment inside a walled-off abscess full of dead neutrophils and bacteria is highly acidic. It has a very low pH.
Correct. Local anesthetics like lidocaine are weak bases. In order for lidocaine to effectively cross the lipid membrane of the nerve sheath and block the sodium channels to stop pain signals, it must be in an unionized state. When you inject that weak base into the highly acidic soup of an abscess, the lidocaine rapidly picks up hydrogen ions. It becomes highly ionized. In that ionized form, it is completely trapped. It cannot cross the nerve cell membrane. The acidic pus literally neutralizes the drug.
So you are causing the patient immense pain with the needle for absolutely zero anesthetic benefit. Stick to the less acidic roof and surrounding tissue.
Okay, let's zoom out and look at general diagnostics for all wounds. X-rays are a massive tool, not just for broken bones, but for ruling out retained foreign bodies. You might think glass wouldn't show up on an X-ray because it's transparent, but the text explicitly notes that standard plain film X-rays are dense enough to detect glass fragments as small as 1 millimeter.
It is an indispensable tool if a patient stepped on a bottle or fell on a glass table. Furthermore, if you're treating a deep laceration and the x-ray reveals a fracture in the bone directly underneath that wound, the diagnosis instantly changes.
How so?
That is no longer just a laceration over a broken bone, but definition that is an open fracture. The protective skin barrier to the bone is broken.
Which means the bone marrow is exposed to the outside world.
Exactly. And that is a dire orthopedic emergency. It requires an immediate surgical consult and the administration of potent, broad-spectrum IV antibiotics within 2 to 3 hours of the injury. If you delay, the bacteria will seed into the bone tissue, causing osteomyelitis, an incredibly difficult to cure bone infection that can lead to chronic pain, repeated surgeries, and potentially amputation.
Now, here's where I want to circle back to our opening hook and play devil's advocate for the student listening. We touched on this, but let's really dig into it. When we talk about wound cleansing and initial irrigation, the textbook explicitly states that potable tap water, just normal water from the sink, is surprisingly superior to sterile normal saline for laceration cleansing.
I know, it sounds crazy.
I really have to push back on this. We spend entire semesters in nursing school drilling sterile technique. We learn how to open packages without touching the inside, how to maintain a sterile field. Using tap water feels completely counterintuitive and reckless.
I completely understand the resistance. It feels entirely wrong until you put aside the concept of a sterile field in a trauma setting and look strictly at the physical fluid dynamics and the overwhelming evidence base.
Okay, walk me through the physics.
Let's look at the goal. The primary objective of wound irrigation is not to bathe the tissue in a sterile fluid. The goal is to physically, mechanically decrease the bacterial count and remove microscopic particulate debris.
Right.
The most effective way to accomplish that is with kinetic energy, specifically a high-pressure stream of fluid aimed directly into the depths of the wound.
You are essentially trying to power wash the bacteria off the tissue.
That is the exact mechanism. You are using sheer force to overcome the adhesive bonds the bacteria have formed with the tissue. The clinical data overwhelmingly demonstrates that the total volume of the fluid used and the pressure of the irrigation matter infinitely more for physically dislodging those pathogens than the microscopic sterility of the fluid itself.
So, because normal saline comes in small, expensive, limited volume bottles, providers tend to be conservative with it. You might use a 500cc bottle and call it good.
Exactly. But with clean, drinkable tap water, you have an endless supply. You can place the patient's arm under the faucet and use massive, copious volumes, liters upon liters of water under excellent pressure.
And the data supports this.
The evidence consistently shows that this high-volume mechanical irrigation with tap water reduces deep infection rates just as effectively, if not slightly more so, than utilizing smaller, cautious amounts of perfectly sterile saline. You are basically washing the threat away.
So volume and pressure are the true heroes of wound care, not the label on the bottle. But speaking of bacterial threats, while a playground scrape or a kitchen knife slip is one thing, what happens when the wound is intentionally inflicted by a mouthful of razor-sharp teeth?
Oh, that's a whole different ballgame.
The bacterial profile and the structural damage require a totally different, highly specialized clinical pathway. Let's shift gears and examine animal and human bites. When nature, and sometimes other people, bite back.
This represents a massive volume of urgent care visits. We're looking at an estimated 2 to 5 million animal bites occurring annually in the United States alone.
Wow. Millions.
Yes. And when you look at the mechanism, the vast majority, over 70%, occur on the extremities, specifically the hands and arms. This happens because the victim is either actively reaching out to pet an unfamiliar animal, or they are reflexively throwing their hands up defensively to protect their face and neck during an attack.
And unfortunately, the demographics show they mostly affect young children who are closer to the animal's face and, less adept at reading aggressive behavioral cues. Now, the absolute foundational rule for bites. Every single bite wound, regardless of how clean it looks, is considered grossly contaminated. The infection risk is astronomical compared to a standard laceration.
And because these bites so frequently involve the hands, your objective neurological exam must be incredibly precise. A simple gross motor test is insufficient.
Okay, what do we need to do?
If a dog's canine tooth punctures the palm or a finger, you have to worry about the tiny digital nerves. We assess this using two-point discrimination, specifically testing on the volar pads, the fleshy, sensitive part of the fingertips.
How exactly do you execute that test in a noisy urgent care room? What is the physiology behind it?
The physiology relies on the density of nerve endings. The fingertips have a massive concentration of sensory receptors. You take a specialized tool or, honestly, An unbent paperclip works perfectly in a pinch. You bend it into a U shape so you have two distinct points.
A paperclip, really?
Oh, yeah, it works perfectly. You instruct the patient to close their eyes or look away. You then gently touch their fingertip, randomly alternating between touching them with only one point or pressing both points down simultaneously. A normal, healthy, uninjured digital nerve has such high resolution that it allows the patient's brain to clearly distinguish two distinct points of pressure, even when those points are less than 5 millimeters apart.
So it's a test of sensory resolution.
Exactly. If you are touching them with 2 points that are 5 millimeters apart, and they confidently tell you they only feel one single point poking them, their sensory resolution is degraded. You have to immediately suspect that the bite physically damaged or severed the digital nerve pathway transmitting that signal.
That's a great clinical test. Let's break down the specific culprits, starting with the most dramatic and potentially lethal, snake bites.
In North America, we primarily deal with pit vipers, rattlesnakes, copperheads, and cottonmouths, and the much rarer coral snakes. The definitive primary treatment for serious systemic envenomation is antivenom. It is a biological marvel, and it is absolutely life-saving. There are two main pharmacological categories. You have monovalent antivenom, which is highly specific and developed against the venom of a single particular species of snake. And then polyvalent antivenom, which is a broader spectrum product designed to neutralize the venom of multiple common snake types within a specific geographic region.
But administering antivenom is never a casual decision. You don't just hand it out for a dry bite. It is often derived from hyperimmunized animal serum, traditionally sheep or horses. Because you are intravenously injecting foreign animal proteins into a human, the risk of triggering a massive, life-threatening anaphylactic immune reaction is very real.
It is a high-stakes clinical calculation. You are constantly weighing the progressive destructive effects of the snake's venom against the inherent, potentially fatal risk of anaphylaxis from the cure.
And obviously, accurately identifying the snake massively helps guide that calculation. The text mentions the old classic adage used to differentiate the highly venomous coral snake from the harmless mimic king snake. The banding patterns are key. Red next to black, friend of Jack. Red next to yellow, kill a fellow.
It's a simple rhyme, but it remains clinically useful in the field. Now, there is a critical red flag highlighted in the text regarding the immediate first aid and field management of snake bites. We've all seen the movies where someone gets bitten and they immediately rip off their shirt, tie a tight tourniquet around the limb, and apply massive pressure to stop the venom from spreading to the heart.
Right. The instinct is to isolate the poison, but the text screams to avoid this for necrotizing venom. Why?
It comes down to the destructive chemistry of the venom itself. Pit viper venom is highly cytotoxic and necrotizing. It is basically a cocktail of digestive enzymes designed to break down and liquefy tissue.
Like acid.
Exactly. If a patient is bitten on the calf and you apply a tight pressure bandage or a tourniquet above the knee, you successfully trap the venom in the lower leg. But you are localizing all of those potent tissue-destroying toxins into one confined anatomical compartment.
Oh, I see.
The venom will absolutely ravage and digest the concentrated area, virtually guaranteeing massive muscle death, compartment syndrome, and the eventual surgical amputation of that limb.
So you sacrifice the leg to save the life.
Except it's not necessary. The current standard of care for necrotizing pit viper bites is to keep the limb immobilized at heart level, keep the patient calm to lower their heart rate, and get them to an ER for antivenom as fast as possible.
You just let it spread?
You let the venom slowly dilute systemically rather than concentrating its destructive power. Pressure immobilization techniques are strictly reserved for neurotoxic venoms, like those from certain exotic snakes or coral snakes, which cause rapid systemic respiratory paralysis but cause very minimal local tissue damage. For those, you consult medical toxicology and poison control immediately.
Okay, moving from the dramatic exotic bites to the everyday occurrences that fill urgent care waiting rooms. Cat, dog, and human bites. Let's establish the fundamental unbreakable rule for suturing a puncture wound from a cat or a deep crush bite on a hand from a dog. What is the protocol?
The protocol is that you do not touch it with a needle. You almost never ever suture them closed. Almost never. These specific wounds are characterized by diminished local vascularization from the crush injury, and they harbor massive, deeply embedded bacterial loads from the animal's saliva.
I always try to visualize it like putting a tight lid on a boiling pot of bacteria. If you have a deep, narrow puncture wound from a needle-like cat tooth, that tooth has injected a slurry of Pasteurella multicida deep into the tissue.
Yes, deep inside.
If you then confidently stitch the surface of the skin perfectly closed, you are literally sealing those bacteria into a dark, warm, nutrient-rich, anaerobic environment. You have just built a perfect incubator. It is a guaranteed explosive abscess waiting to happen.
That is exactly what happens. Instead of closing it, your management is aggressive mitigation. You heavily, copiously irrigate the wound tract, often under pressure.
Yeah.
You surgically debride, cut away any shredded, devitalized, or dead tissue, because dead tissue is just food for bacteria.
Right.
And then, crucially, you leave the wound completely open. You allow it to heal by secondary intention, slowly granulating and healing from the inside out, allowing any purulent discharge to naturally drain away.
Or, if it is a large cosmetically sensitive wound, you might utilize delayed primary closure, which is healing by for sheer intention.
Yes. In that scenario, you aggressively clean the wound, pack it open with moist, sterile gauze, and send the patient home with antibiotics. You have them return in 3 to 5 days. You remove the packing and evaluate the tissue.
What are you looking for?
If the wound bed is perfectly clean, pink, and shows 0 signs of infection after that incubation period, you can safely proceed to suture it closed at that delayed stage.
And we absolutely have to talk about the pharmacological armor we use, antibiotics. The established gold standard prophylactic antibiotic for cat bites, high-risk deep dog bites, and especially human bites is amoxicillin clavulanate, commercially known as Augmentin.
Augmentin is the drug of choice because it provides excellent broad-spectrum coverage against the specific aerobic and anaerobic flora found in oral cavities, particularly Pasteurella in cats and dogs, and Eichinella corrodens in humans. It's typically prescribed for a 3 to 5 day prophylactic course.
And speaking of human mouths, we need to circle back to the pathophysiology of the fight bite we touched on earlier. This is a closed fist injury. Let's walk through the exact mechanics of how this disaster happens.
It's a crazy mechanism.
Someone clenches their fist, pulling the extensor tendons tight over their knuckles. They punch another person directly in the mouth. The opponent's incisor tooth violently penetrates the skin over the knuckle, slices right through the taut extensor tendon, and breaches the joint capsule beneath it, depositing human saliva directly into the joint space.
Yes.
Then the punch connects, and the person recoils and opens their fist.
And that opening of the hand is where the physiological trap is sprung. When the fingers extend and the hand opens, the extensor tendon mechanically glides back up the arm to its resting position.
It pulls back.
Exactly. As it glides, it physically pulls the deposited bacteria deep into the dorsal compartments of the hand. Even worse, the sliding tendon totally misaligns the original puncture tracts in the skin, the tendon sheath, and the capsule.
It closes the door behind it.
It acts like a sliding valve, completely sealing the entry tract closed. The bacteria are trapped deep within the closed joint and the tendon sheaths with 0 route for drainage.
It is a biomechanical nightmare. It looks like a tiny 2-millimeter scrape on the surface of the knuckle, but deep inside, a highly destructive anaerobic infection is brewing.
Which is why you treat every single knuckle laceration with extreme suspicion. A true fight bite is a devastating injury that requires immediate hospital admission, strong parenteral IV antibiotics, and an urgent orthopedic consult for surgical exploration and a high-pressure washout in the operating room.
Now, before we leave bites, here is a complex scenario to extrapolate on. What if you are working in primary care and a terrified parent brings in their 2-year-old toddler? The child has a clear, distinct bite mark on their forearm, but they are too young or too hysterical to explain what actually bit them. Was it the family dog, a stray feral cat in the yard, or was it an older sibling acting out?
This is a scenario where your role instantly expands from simple clinician to medical detective and public health officer. It is incredibly fraught. First, forensically, you actually have to measure the intercanine distance, the physical space between the puncture marks left by the canine teeth, to help objectively differentiate a human bite mark from an animal bite mark.
Because the treatment protocol and the social implications swing wildly based on that answer.
Exactly. If it's a wild animal or an unprovoked attack by a stray dog that fled the scene and cannot be immediately located and quarantined by animal control, you are suddenly thrust into the time-sensitive calculus of rabies post-exposure prophylaxis. You have to initiate the rabies vaccine series and immunoglobulin.
And if it's human?
Conversely, if you determine it is definitively an adult human bite mark on a toddler, you are legally and ethically mandated to navigate the deeply uncomfortable intersection of Child Protective Services and abuse reporting. This single presentation isn't just about treating a wound. It is about expertly navigating public health mandates, epidemiological risk, and severe patient safety protocols.
It really highlights how complex primary care trauma can be. So we've covered the macroscopic biters, the dogs, cats, snakes, and humans. But sometimes the most complex, difficult to manage systemic reactions come from the absolute smallest culprits. Let's transition to section 3, arthropod bites and stings. Tiny creepers causing massive physiological reactions.
The clinical challenge with arthropods is that they are stealthy. Often the patient never saw the bug, they didn't feel the initial bite, they only present to your clinic days later when the bizarre spreading rash appears or the severe systemic symptoms finally kick in.
So it's a mystery.
Exactly. Diagnostics in this realm rely heavily on your ability to recognize specific cutaneous rash patterns and having a deep understanding of the local indigenous bugs in your specific geographic region. For tick-borne illnesses, which are rampant in many areas like Lyme disease from the Ixodes tick or Rocky Mountain spotted fever, we frequently rely on serological testing, specifically antibody titers.
And for the MP student, you absolutely have to understand the immunological difference between testing for IgM and IgG antibodies. If you mix these up, you will wildly misdiagnose your patient.
Let's break down the immunology. IgM is your acute phase reactant. Think M for the immediate moment. It is the very first antibody the immune system deploys when it encounters a novel pathogen.
Right.
If a patient's lab results return with significantly elevated IgM titers for Lyme disease, it strongly indicates an acute, highly active current infection that requires immediate antibiotic treatment.
And IgG.
IgD takes much longer for the body to manufacture, often weeks to months. It represents long-term immune memory, past exposure, or a successfully cleared infection.
So it's historical.
Yes. If a patient presents with elevated IgG, but completely normal, low IgM, they are not currently infected with the active bacteria. Their body is simply showing you the historical record that they fought it off in the past. Treating a high IgG with heavy antibiotics is a clinical error.
Let's break down the specific management strategies by bug type, because the pharmacology and treatments vary wildly depending on the venom. Let's start with Hymenoptera, the bees, wasps, and hornets.
The primary clinical pearl here is specific to honeybees. Their stingers are barbed. When they sting, they physically tear the stinger, along with the pulsating venom sac, right out of their own abdomen, leaving it embedded in the patient's skin. The venom sac will continue to actively pump venom into the tissue for minutes after the bee is gone. Your first instinct might be to grab the stinger with tweezers to pull it out.
But if you do that, you're gripping the venom sac.
Exactly. You squeeze it with tweezers, you act like a syringe, forcefully injecting the entire remaining load of venom directly into the patient. You must use a blunt edge like a credit card or the back of a scalpel blade to gently scrape laterally across the skin to catch the stinger and flick it out without compressing the sac.
Now, for localized pain, ice and antihistamines work. But for severe systemic anaphylactic allergic reactions, where the venom triggers a massive release of histamine causing airway edema and cardiovascular collapse, you are immediately moving to emergency management. You need systemic intramuscular epinephrine to reverse the vasodilation and bronchodilation, and potentially IV calcium gluconate to manage severe muscle spasms.
Next on the list of nightmares, the brown recluse spider. Found frequently in the Midwestern and Southern U.S., hiding in dark, undisturbed places like attics and old shoes. They are known for their venom, which causes profound local tissue necrosis.
How does the venom work?
The venom contains sphingomyelines D, an enzyme that literally destroys cell membranes and triggers massive local thrombosis, cutting off blood supply to the skin. Treatment is largely supportive. Cold compresses to slow the enzymatic activity, elevation, and antibiotics only if the necrotic ulcer becomes secondarily infected.
Okay.
However, for rapidly spreading severe necrotic wounds, a systemic drug called dapsone is sometimes employed to inhibit the neutrophil migration that exacerbates the tissue destruction.
But there is a massive, absolute screaming caveat with dapsone that every prescriber must memorize.
You absolutely must draw blood and screen the patient for G6PD deficiency before you ever write that prescription. Glucose 6-phosphate dehydrogenase deficiency is a relatively common genetic enzyme defect, particularly in certain ethnic populations. That enzyme protects red blood cells from oxidative stress.
And dapsone causes oxidative stress.
Yes. If you administer dapsone to a patient who lacks the protective G6PD enzyme, it will trigger a sudden, severe, and potentially life-threatening hemolytic anemia. The oxidative stress will literally cause their red blood cells to rapidly rupture and die in the bloodstream.
You trade a skin ulcer for a hematological crisis. Okay, what about the other famous spider, the black widow?
Black widow venom is fundamentally different. It is a highly potent neurotoxin, specifically alpha-laterotoxin. It doesn't dissolve tissue. Instead, it causes a massive, uncoordinated release of acetylcholine and norepinephrine at the nerve synapses.
What does that look like clinically?
Clinically, this presents as incredibly severe, agonizing, board-like muscle spasms. It frequently causes a rigid, cramping abdomen that is so intense it can perfectly mimic the presentation of an acute surgical abdomen, like a ruptured appendix. Management focuses on treating the spasms with IV calcium gluconate and aggressive use of muscle relaxants and anxiolytics like Valium.
But here's where the text gets incredibly specific about pain management, and I want to highlight this for the student. It's fascinating how a routine painkiller becomes contraindicated based entirely on the specific chemistry of the venom. Why are standard opioids like morphine an absolute hard no for black widow bites and similarly contraindicated for scorpion stings?
It comes down to understanding complex pharmacodynamics. When alpha-laterotoxin from a black widow forces the release of neurotransmitters, it also induces a massive systemic histaminic response. The patient's body is flooded with histamine. Now look at opioids. Medications like morphine have a known side effect. They possess a histaminic agonist effect. They naturally cause the body to release even more histamine.
Wait, so if the venom is already causing a dangerous histamine cascade and morphine also causes a histamine release, giving them that opiate for pain is basically pouring pharmacological gasoline on a fire.
That is precisely what you are doing. You will compound the histamine cascade, severely worsening the systemic reaction, increasing the swelling, and potentially pushing them into a shock-like state. You have to find alternative pain control.
What about for scorpions?
The reasoning for scorpions is different, but equally dangerous. Scorpion venom heavily hyperstimulates the nervous system. The patient is already at risk of losing airway control due to spasms and secretions. If you combine that severe neurological toxicity with the profound respiratory depression that opiates naturally cause, you can rapidly induce fatal apnea. The synergistic effect will cause the patient to simply stop breathing entirely.
It is an incredible example of why you must know why a drug works, not just what it is used for. Before we leave the topic of bugs, we have to talk about differential diagnosis. A patient walks in complaining of an intensely itchy, blistering rash. They swear they have bed bugs or spider bites, but it's not always a bug.
True. This is where you have to broaden your differential. If they present with a classic expanding bullseye rash erythema migrans, you test for Lyme disease. But if they present with intensely pruritic small red papules, especially wards at night, you have to consider a parasitic infestation like scabies.
Scabies, right.
Scabies mites burrow under the skin, classically favoring the warm, tight web spaces between the fingers, the wrists, and the belt line. Its onset is gradual. You also have to consider environmental fleas.
And the textbook even throws in a systemic, non-infectious autoimmune condition into this differential, dermatitis herpetiformis.
Yes, which is a brilliant addition to the chapter. Dermatitis herpetiformis is essentially the intense cutaneous manifestation of underlying celiac disease. The body produces IgA antibodies against gluten, and those immune complexes deposit in the skin.
So it looks like bug bites.
It presents with grouped, intensely itchy vesicles that look remarkably like insect bites. In fact, they are often heavily excoriated, scratched open, and bleeding because the pruritus is so unbearable. If you have a patient who keeps returning to your clinic week after week with mysterious bug bites that completely fail to respond to standard topical steroids or permethrin creams, you must elevate your clinical thinking.
You have to look deeper.
You have to broaden your differential to include deep systemic or autoimmune causes like celiac disease.
All right, we've covered venom and chemical toxins injected by tiny fangs and stingers. We are now going to move to massive, sweeping physical and chemical destruction of the skin tissue itself. Let's talk about burns, heat, caustic chemicals, and the vital mathematics of fluid resuscitation.
Burns are incredibly common and deceptively complex, with almost 500,000 series of burn injuries requiring medical treatment annually in the U.S. When a burn patient arrives, your absolute first diagnostic job, after securing the airway, is accurately assessing the exact depth of the thermal destruction.
Let's break down the exact clinical presentation of these layers, because this assessment directly dictates whether the patient is sent home with a cream or flown by helicopter to a specialized burn center.
We start with superficial or first-degree burns. This thermal injury involves only the very top layer, the epidermis. Think of a classic mild sunburn from a day at the beach. The skin is dry, it is erythematous, it hurts to touch, but crucially, it completely blanches, turns white when you apply pressure, and then the redness returns.
As the energy penetrates deeper, we hit superficial partial thickness, or second-degree burns.
This breaches through the epidermis and partially cooks the upper layer of the dermis. This is the exact depth where you see the classic, tense, fluid-filled blisters and vesicles form. The exposed skin underneath the blisters is extremely moist, bright red, and exquisitely highly hypersensitive to even a breeze of air because the superficial nerve endings are irritated but still alive.
Now, distinguishing between the next two categories in an urgent care setting is notoriously difficult, but it is critical for triage. Deep partial thickness versus full thickness.
It is tough. Deep partial thickness burns destroy the epidermis and the vast majority of the deeper dermis. The wound bed loses that bright red weeping appearance. Instead, it looks pale, mottled, waxy, or pearly white. And here's the key clinical finding. It is often completely insensate.
Because the thermal energy has literally cooked and destroyed the deep Meissner and Pacinian corpuscles, the specialized nerve endings in the skin. They can't feel pain there anymore, which sounds terrifyingly identical to full thickness or third-degree burns.
The presentations overlap heavily. Full thickness implies total destruction. It destroys all skin layers, epidermis and dermis, and penetrates down into the subcutaneous fat, the tough fascia, or even the underlying muscle. The clinical picture is stark.
What does it look like?
You will see a thick, dry, rigid, leathery eschar. The color can be stark white, cherry red from fixed hemoglobin, or charred deep black. It is utterly insensate. Furthermore, if you look closely, you will often see thrombosed, heat-coagulated blood vessels frozen within the dead wound bed. Because the entire regenerative stratum germinativum layer is gone, full-thickness burns will absolutely never heal on their own. They strictly require surgical excision and skin grafting.
Beyond the localized skin destruction, we have to look at the massive systemic diagnostics, especially if the history involves an enclosed fire, like a house fire or a car fire. We have to assume smoke inhalation. And the critical life-saving blood test here is the carboxyhemoglobin, or COHB level.
Smoke is full of carbon monoxide gas. Carbon monoxide is deadly because it binds to the hemoglobin molecule in your red blood cells with an affinity that is roughly 200 times greater than oxygen.
200 times?
Yes. It physically kicks oxygen out of the seat and refuses to leave. It literally chokes the body's cells at the molecular level, even if the patient is breathing normally.
So we draw the blood and look at the percentage. A normal level for a non-smoker is less than 10%. But as it climbs, the neurotoxicity begins.
At 20% carboxyhemoglobin, the patient begins to look intoxicated. You see severe headaches, profound nausea, and a noticeable loss of fine motor dexterity. At 30%, the systemic hypoxia becomes critical. They exhibit deep confusion and lethargy. And if you run an EKG, you will frequently see ST segment depression, which is a classic sign of cardiac ischemia because the heart muscle itself is starving for oxygen.
And when those numbers hit 40% to 60%?
That is profound coma and impending death. Any patient with suspected inhalation injury needs 100% high-flow oxygen via tight non-rebreather mask immediately, the second they hit the door. Oxygen is the only antidote. It competitively forces the carbon monoxide off the hemoglobin. If their levels hit 40% or if they are pregnant or show severe neurological signs, they must be urgently transferred to a specialized facility for hyperbaric oxygen therapy, which uses massive atmospheric pressure to drive oxygen into the tissues.
Let's quickly touch on the non-thermal burns discussed in the chapter. Chemical burns cause tissue death through rapid protein coagulation or liquefaction. Cold injuries, like severe frostbite, literally cause microscopic ice crystals to form within the interstitial fluid, which mechanically spike and rupture the delicate cell membranes from the outside in.
But electrical burns are perhaps the most deceptive and terrifying. The visible skin injury might look incredibly small, just a tiny charred entrance wound on the finger and an exit wound on the toe. But electricity follows the path of least resistance through the body, which unfortunately happens to be our internal nerves and our fluid-filled blood vessels.
It essentially uses the cardiovascular system as a copper wire.
Exactly. The high-voltage current silently cooks the deep tissues from the inside out. This causes massive, hidden skeletal muscle destruction. When muscle dies, it releases massive amounts of a protein called myoglobin into the bloodstream. This myoglobin is a large molecule that quickly clogs the delicate filtration tubules of the kidneys, rapidly leading to acute, devastating renal failure.
And the heart.
Furthermore, the electrical current can severely disrupt the heart's intrinsic electrical conduction system, causing fatal, sudden cardiac arrhythmias hours or even days long after the initial shock. They require intense EKG monitoring and massive 5E fluid flushing to protect the kidneys.
Okay, let's talk about the mathematics of burn management. You have a burn patient. You have to calculate the total body surface area, or TBSA, that is burned. This number dictates everything about their fluid resuscitation. We use the classic rule of nines for adult patients.
It is a rapid estimation tool. The adult body is divided into broad anatomical areas, each representing roughly 9% of the total surface area. The entire head and neck is 9%. Each full arm, front and back, is 9%. The anterior torso is 18%, and the posterior back is 18%. Each full leg is 18%. The perineal area represents the final 1%.
And for scattered burns?
And for smaller, scattered, irregularly shaped burns, we use the patient's palm, not the provider's palm, but the patient's palm size, including the fingers, roughly equals 1% of their TBSA.
Why is this math so critical? Because if they have a major burn, generally defined as over 20% TBSA in an adult, they are inevitably going to slide into burn shock.
Burn shock is a form of massive hypovolemic shock, but it's unique. The profound thermal injury triggers a massive systemic inflammatory response. Capillary leak syndrome occurs globally throughout the body. The blood vessels become incredibly porous, and vast amounts of plasma and intravascular fluid leak out of the blood vessels and pool into the interstitial tissue spaces, causing massive whole-body edema. The fluid isn't leaving the body, but it is leaving the circulatory system. The heart has nothing left to pump.
So their blood pressure plummets. You need a large bore IV or two immediately, and you begin infusing massive volumes of lactated Ringer solution to refill the vascular tank and maintain organ perfusion. Now let's zoom in from systemic shock back to the skin itself. Let's dive into the pharmacological nuances of topical burn treatments.
The goal of topicals is to prevent bacterial colonization of the dead tissue. Gesitracin ointment is fantastic for superficial clean burns, especially on highly sensitive cosmetic areas like the face, because it is gentle and transparent. However, it is useless on deep burns because it completely fails to penetrate through thick, leathery eschar.
What about yeast infections?
If you suspect a yeast or fungal infection in a chronic burn, you pivot to clotrimazole. But for severe, deep wounds, we have to look at the heavy hitters, like mafenide acetate, also known as sulfamylon.
Mafenide is fascinating. It's an excellent agent precisely because it possesses the unique chemical ability to penetrate deeply through thick, dead eschar tissue, reaching the bacteria hiding underneath. This makes it the absolute drug of choice for treating deep electrical burns and complicated burns on the cartilage of the ears. But there is a massive metabolic side effect you must monitor for.
You must monitor them closely for hyperchloremic metabolic acidosis. Mafenide acetate acts as a potent systemic inhibitor of carbonic anhydrase. If applied over a large surface area, it absorbs into the bloodstream and fundamentally alters the patient's renal acid-base balance, causing a severe drop in blood pH.
Wow.
The patient might start hyperventilating, showing small respirations just to blow off CO2 to compensate for the acidic cream you smeared on their skin.
It's a crazy systemic effect from a topical cream. Silver nitrate is another older option. It's highly antimicrobial, but it is notoriously messy. It chemically stains absolutely everything it touches, stark black, the wound bed, the surrounding unburned skin, the hospital bed sheets, the provider's clothes, and more dangerously, it aggressively leaches essential electrolytes, specifically sodium and potassium, directly out of the wound bed. You have to compulsively monitor their blood chemistry.
Which brings us to the most ubiquitous, widely prescribed agent in urgent care and burn units, silver sulfadiazine, commonly known as Silvadene. It is a thick white cream that provides an excellent broad spectrum of antimicrobial activity while being relatively painless to apply.
I see Silvadene used constantly. It is handed out like candy for burns. But I want to push back on this one. I was reading the textbook closely, and it explicitly notes that a known side effect of Silvadene is transient neutropenia, a sudden drop in circulating white blood cells. That seems like a massive counterproductive catch. You are putting a cream on a severely burned patient who has lost their primary skin barrier and is highly susceptible to deadly sepsis, and the cream itself suppresses their immune system.
It is a profound pharmacological irony, and it is a significant clinical consideration that many providers overlook. The neutropenia is a bone marrow suppression effect that usually occurs rapidly, typically after 2 to 3 days of continuous application. As an advanced practice provider, You are constantly making risk-benefit calculations. You have to weigh the massive, proven, broad-spectrum antimicrobial benefit of the silver against this risk of transient bone marrow suppression.
So how do you manage that practically?
For a minor, isolated 2% TBSA burn on an otherwise healthy young adult, the systemic absorption is minimal. It's usually extremely well tolerated, and if a mild neutropenia occurs, it quickly resolves without consequence once you stop the cream. But for a patient with a major expansive burn, you are slathering large volumes of this drug onto their body daily. You absolutely must be drawing serial complete blood counts every few days to specifically monitor their white cell trajectory.
And if it drops?
If those neutrophils drop precipitously low, crossing the threshold into dangerous territory, you have to immediately discontinue the Silvadene and switch to a different agent. It is a highly effective tool, but it is absolutely not a benign, harmless lotion.
Let's touch on one more specialized trauma scenario before we move on. You are working your urgent care shift. A frantic patient runs in. They just had a major accident in a high school chemistry lab or an industrial manufacturing plant. They are covered in a caustic burning chemical. We have to initiate the chemical shower protocol.
Step 1, before you even look at the patient, protect yourself. You cannot become a secondary victim. You must immediately don full personal protective equipment gloves, GAN, face shield. Then you get the patient to the decontamination shower instantly. The clock is ticking on tissue destruction.
And here is a crucial logistical step. You must remove all of their saturated clothing while they are actively under the running water being rinsed. Do not have them undress first. And specifically, if they are wearing a pullover shirt soaked in acid, do not let them grab the hem and pull that toxic chemical-soaked fabric up and over their face and eyes. Use trauma shears and physically cut the clothing off their body to avoid spreading the exposure.
And pay attention to the nature of the chemical. If it is a dry, caustic powder, you must vigorously brush the dry powder off their skin first before you ever turn the water on. Some dry industrial chemicals react violently and exothermically with water, creating an intense thermal burn on top of the chemical burn.
And while water is the universal diluter, there are specific, highly dangerous chemicals that require specialized antidotes. Hydrofluoric acid, which is commonly used in industrial glass etching and heavy-duty rust removers, is utterly terrifying.
Hydrofluoric acid is unique because the fluoride ion penetrates incredibly deeply through the skin and binds aggressively to the calcium in the patient's deep tissues and bones. It causes agonizing, deep pain and massive tissue death. Copious water irrigation is not enough. You have to chemically neutralize the fluoride.
How do you do that?
You must perform multiple, painful subcutaneous injections of calcium gluconate directly into and completely surrounding the burned tissue. You are providing the fluoride with substitute calcium to bind to, saving the patient's actual tissue calcium.
And another specific agent is phenol, a very strong caustic industrial disinfectant. Phenol is lipophilic. It is actually much more soluble in alcohol or polyethylene glycol than it is in standard water.
Exactly. Rinsing a phenol burn with water alone is highly inefficient. If your industrial clinic stocks a 50% polyethylene glycol, or PEG solution, you aggressively scrub the skin with sponges soaked in PEG. The PEG acts like a chemical magnet, physically pulling the phenol out of the lipid layers of the skin far more effectively than water ever could.
So we spend a massive amount of time covering the outer armor of the body, the complex layers of the skin, how it tears, how it burns, and how it reacts to venom. But what happens when the violent trauma involves a sudden, massive deceleration force that shakes the most vital, delicate organ we possess? Let's transition to the invisible injuries locked inside the body's vault. Head trauma. Time, pressure, and the delicate brain.
Head trauma is an incredibly heavy topic. It is a leading cause of severe morbidity, permanent disability, and mortality worldwide. When we look at the epidemiology, high-speed motor vehicle accidents often come to mind. But statistically, simple falls are the absolute number one cause of traumatic brain injury. And this disproportionately affects the two extremes of age. The very young, who are unsteady and have large heads relative to their bodies, and the elderly, frail population.
And the textbook makes a deeply critical, highly practical point about intoxicated patients. If an intoxicated patient falls and hits their head, you are in a massive diagnostic bind. Alcohol profoundly masks the subtle neurological symptom of an evolving cerebral injury. Their baseline mental status is already heavily altered. They are slurring words, stumbling, and confused. You simply cannot rely on your standard physical exam to tell you if they are acting bizarre because of the 6 beers or because they have a slowly expanding pool of blood crushing their frontal lobe.
It is a terrifying scenario. The rule is absolute.
Yeah.
You must maintain a microscopically low threshold for advanced imaging. An intoxicated patient with evidence of head trauma almost universally requires a CT scan to definitively rule out a bleed, and they require strict clinical monitoring until they are completely clinically sober and you can obtain an accurate baseline neurological exam. You cannot safely discharge them to sleep it off.
Let's look at the actual pathophysiology of the trauma. What is physically happening inside the skull? Mild head trauma, like a classic concussion, is usually a deceleration or rotational shearing injury.
Think about the anatomy. The human brain is a soft, gelatinous mass suspended in a bath of cerebrospinal fluid inside a rigid, unforgiving, bony skull. When a patient is in a car crash or falls, the head is moving rapidly and then suddenly stops against the steering wheel of the pavement. But physics dictates that the soft brain keeps moving forward inside the skull.
It violently impacts the hard internal ridges of the anterior skull, the coup injury, and then bounces backward to strike the posterior skull, the contracute injury.
Exactly. And during that violent sloshing, the long, delicate neuronal axons and the microscopic blood vessels are twisted, stretched, and physically sheared apart.
And if the forces are strong enough to tear the fragile bridging veins that connect the outer cerebral cortex to the dural venous sinuses, you get a slow venous bleed. That is a subdural hematoma. The text notes a fascinating and terrifying point about subdurals. They can happen completely spontaneously or with incredibly trivial trauma in the elderly population.
The mechanism there is purely anatomical. As the human brain naturally ages, it undergoes cortical atrophy. It physically shrinks. Because the brain is smaller, there is more empty space inside the skull. This means those delicate bridging veins are pulled tight, stretched across a wider gap. They are under constant baseline tension. A very minor force, like an elderly patient simply bumping their head on a kitchen cabinet door, is enough to snap a stretched vein, starting a slow, insidious venous bleed that might not cause severe symptoms for weeks.
Contrast that slow venous bleed with a subarachnoid hemorrhage.
A subarachnoid hemorrhage involves rapid, high-pressure arterial bleeding directly into the subarachnoid space, mixing with the CSF. While it can be caused by severe trauma, it results far more commonly from the spontaneous rupture of a pre-existing intracranial baryaneurysm. The clinical presentation is unmistakable. It is an explosive onset, classically described by the patient as the absolute worst thunderclap headache of my life, rapidly accompanied by profound neck stiffness and photophobia as the blood intensely irritates the meninges.
Let's talk about the overarching consequence of all these bleeds and bruises. The vicious, lethal cycle of increased intracranial pressure, or ICP. I like to conceptualize the skull as a closed, heavy steel bank vault. It is made of solid, unyielding bone.
That is the perfect physiological model. It is known as the Monroe-Kelly hypothesis. That solid bone vault contains exactly three elements: the physical brain tissue, the circulating blood, and the cerebrospinal fluid. Because the vault cannot expand, the total volume inside must remain absolutely constant. If you add a fourth element, like a rapidly expanding pool of blood from a torn artery or massive cellular swelling and edema from bruised tissue, something else inside that vault has to give way to make room.
But there's nowhere to go.
That is the exact trap. Initially, the body tries to compensate by squeezing CSF down into the spinal cord or constricting veins to push blood out, but those compensatory mechanisms fail rapidly. Once the vault is full, the pressure spikes exponentially.
And then the death spiral begins.
The localized area of injury becomes ischemic from the pressure. It starves for oxygen and swells further. The delicate physiological autoregulation of the brain, the system that keeps blood flow constant, is completely lost. The blood-brain barrier physically breaks down under the strain, causing plasma fluid to leak uncontrollably into the brain tissue, massively elevating the ICP. As the ICP skyrockets, it physically chokes off the incoming cerebral arterial blood flow. The brain detects this severe hypoxia. In a desperate, flawed attempt to get more oxygen, the brain signals massive cerebral vasodilation. The arteries open wide to bring in more blood.
But pouring more arterial blood into an already overpressurized, closed steel vault only increases the swelling and drives the ICP even higher.
It is a catastrophic positive feedback loop. If this spiral is not rapidly identified and reversed medically or surgically, the immense crushing pressure forces the soft brain tissue downward, seeking the only available physical exit from the vault: the foramen magnum, the large opening at the base of the skull where the spinal cord exits. That process is called brain herniation. The brain stem is crushed against the bone, shutting down the basic primitive centers for respiration and cardiac function, causing irreversible brain death.
So as the clinician at the bedside, your objective physical exam is quite literally a race against the clock to catch this process early. You must meticulously assess the cranial nerves because they are the wiring that runs through this pressurized vault. Let's run through this not as a textbook list, but as an actual clinical exam.
Excellent. You start with cranial nervi, the olfactory nerve. You ask if they've noticed a change in their sense of smell. Traumatic anosmia, the complete loss of smell, is highly common with severe frontal impacts because the delicate nerve filaments running through the cribriform plate are violently sheared off.
Cranial nerve 2, the optic nerve. You check their visual acuity and visual fields. You are looking for visual field cuts or a pupil that is completely unreactive to direct light, indicating optic nerve compression. But the critical nerve for detecting rising ICP is cranial nerve 3, the oculomotor nerve.
Yes. CN3 controls the pupillary sphincter and most eye movements. As the brain begins to swell and shift downward, it physically pinches and compresses the oculomotor nerve against the tentorium. This causes the classic blown pupil, a widely dilated pupil that completely fails to constrict when you shine a bright light into it. You might also see severe cactosis, a drooping of the upper eyelid. If you see a unilateral blown pupil in a trauma patient, you have to assume they are actively herniating.
Cranial nerve 4, the trochlear nerve. You ask them to follow your finger down and in toward their nose. If they can't, CNIV is damaged. Cranial nerve, the trigeminal nerve. You lightly touch their forehead, cheek, and jaw with a cotton swab to check for symmetrical facial sensation, and you check the corneal reflex. Cranial nerve 6, the abducens. You ask them to look outward, away from their nose. Failure of the eye to abduct means CN5 is compromised.
Cranial nerve 7, the facial nerve, requires a nuanced understanding. You ask them to smile, puff their cheeks, and raise their eyebrows. If you see weakness, you must differentiate the source. If the peripheral lower motor neuron is damaged by trauma to the face itself, you will see ipsilateral weakness, meaning the entire side of the face from the forehead down to the mouth is paralyzed on the same side as the injury, similar to Bell's palsy. But if the trauma caused a bleed deep in the brain, damaging the upper motor neuron, you will see contralateral weakness, meaning the weakness is on the opposite side of the body, and crucially, it only affects the lower half of the face, sparing the forehead muscles.
It's an incredible diagnostic clue just from asking them to smile. And finally, cranial nerve 8, the acoustic nerve. You check for acute hearing loss, profound dizziness, or nystagmus. Now, beyond the delicate nerves, what are the stark physical red flags on the outside of the head that indicate a catastrophic basilar skull fracture at the floor of the vault?
You are looking for very specific patterns of bruising and fluid leakage. Look inside the ear with an otoscope for hemotympanum, which is a dark pooling of blood trapped directly behind the eardrum. Look behind the ear for battle sign, which is distinct, dark bruising over the mastoid bone. Look at their face for raccoon eyes, which is deep bilateral periorbital ecchymosis, bruising pooling around both eyes. And critically, look for any clear, watery fluid continuously draining from the nose or the ears. That is not a runny nose, that is CSF rhinorrhea or otorrhea. The protective duramater has been torn, and the brain's fluid is literally leaking out.
And what about the late systemic vital sign changes of severely increased ICP, the infamous Cushing reflex?
The Cushing triad is a desperate, late-stage sympathetic nervous system response to profound brainstem ischemia. The brainstem senses it is dying from lack of blood flow due to the crushing pressure. In a final, massive effort to force blood up into the head, the sympathetic system fires, causing a massive spike in systolic blood pressure. You will see a drastically widened pulse pressure, for example, a blood pressure of 210/80. The systolic shoots to the moon while the diastolic stays normal. Concurrently, you will see profound bradycardia, a very slow heart rate, as the vagus nerve is stimulated by the high pressure. Finally, you will observe altered, erratic, irregular respiratory patterns. If you see the Cushing triad at the bedside, medical management has failed, and brainstem herniation is imminent or already occurring.
Diagnostics. Who definitively gets a CT scan? We can't scan every bumped head.
The decision rules, like the Canadian CT head rule, are very clear. A non-contrast head CT is strictly indicated for any patient with a Glasgow Coma Scale score of 14 or less, any documented history of a loss of consciousness, a significant dangerous mechanism of injury like a fall from an elevation or being struck by a vehicle, any post-traumatic amnesia or impaired memory, or any focal neurological deficit found on your exam.
And there is one absolute non-negotiable rule that overrides everything else. Anyone on systemic anticoagulants or antiplatelet therapy like warfarin, Eliquis, or Plavix who sustains any head trauma gets a CT scan. Period. No exceptions. Even if it was a minor bump and they feel perfectly fine, Their blood cannot clot, and a slow, invisible subdural bleed is highly probable. Now, for management, if the CT is negative and the patient is deemed safe to go home with a mild concussion, your patient education is absolutely vital.
They cannot go home alone. They strictly require a competent, reliable caregiver who is explicitly instructed to wake the patient every 2 to 4 hours throughout the night to perform a basic neurological check, asking them their name, assessing their gait. They need strict written return precautions to come back immediately if they develop a severe worsening headache, intractable vomiting, sudden unequal pupils, or distinct personality changes like sudden combativeness.
And here is a piece of long-term management that is tragically overlooked in primary care: psychiatric follow-up.
The clinical research on the psychiatric aftermath of brain injury is absolutely staggering. The prevalence of developing a new psychiatric illness in the first full year following a moderate to severe traumatic brain injury approaches nearly 49%, almost half. And even patients with supposedly mild TBIs or concussions see a massive 34% incidence rate. This isn't just a psychological reaction to the trauma event. The sheer physical shearing forces violently alter the deep neurochemistry of the brain and damage the delicate regulatory pathways in the frontal lobe. You, as the primary care provider, must proactively monitor these post-concussive patients for months, screening them heavily for severe depression, anxiety disorders, and profound affective dysregulation.
Okay, if head trauma is fundamentally a problem of a tightly closed box struggling with far too much pressure, our final topic is the exact catastrophic opposite. It is about a vital cavity losing its essential life-sustaining negative pressure vacuum. Section 6. Thoracic trauma in foreign bodies. The hidden killers of air and blood.
To understand thoracic trauma, you have to understand the physics of breathing. The pleural space, the microscopic gap between the parietal pleura lining the inside of the chest wall and the visceral pleura wrapping the outside of the lung, is normally a potential space held tightly together by negative pressure.
I always picture it like two smooth, wet panes of glass stuck together. You can easily slide them back and forth against each other, but the suction makes it almost impossible to pull them directly apart.
That is a perfect physical demonstration. That vacuum seal is what mechanically pulls the soft lung tissue outward, forcing it to expand and fill with air when the muscular chest wall expands during inspiration.
But if that delicate pleural membrane is ruptured, the vacuum seal is instantly broken. If air rushes into that space, you have a pneumothorax. If blood rapidly fills the space from a torn vessel, you have a hemothorax. The negative pressure is obliterated, the panes of glass separate, and the elastic lung simply collapses inward on itself like a deflated balloon.
The causes of this rupture vary widely. They can be violently traumatic, such as a high-speed steering wheel impact causing a sharp, jagged rib fracture to physically puncture inward through the pleura. They can be iatrogenic, meaning the medical team accidentally caused it, which unfortunately happens during the blind insertion of central venous catheters into the subclavian vein. Or they can be entirely idiopathic and spontaneous. We frequently see this in tall, thin young men or in chronic COPD patients when a fragile emphysematous bleva, a weakened, air-filled blister on the surface of the lung, simply pops under normal breathing pressure.
The patient will classically present with sudden, sharp pleuritic chest pain and severe dyspnea, struggling for breath. But here is the terrifying progression. If it develops into a tension pneumothorax, the mechanism becomes lethal.
Yes. In a tension pneumothorax, the tear in the lung acts as a one-way valve. Air is forcefully sucked into the pleural cavity every time the patient takes a breath in, but the flap of torn tissue closes when they exhale. The air cannot escape. With every single breath, the pressure inside the chest cavity builds higher and higher.
And that massive building pressure eventually pushes everything else out of the way. It forcefully shifts the entire mediastinum, the heart, the trachea, the major vessels, over to the opposite uninjured side of the chest.
And when that massive shift occurs, the immense physical pressure literally kinks the superior and inferior vena cava shut. Blood can no longer return to the right side of the heart. The heart is pumping completely empty. The patient will rapidly crash into profound, irreversible hypovolemic shock despite having plenty of blood in their body, simply because the blood cannot physically reach the heart.
Diagnostically, before it gets to that point, your physical exam is key. Auscultating absent or severely diminished breath sounds over the affected lung field has a remarkably high positive predictive value. But when you move to imaging, there is a critical absolute rule. You must obtain an upright PA and lateral chest X-ray.
You cannot cut corners here. Why is the upright position so critical? It relies entirely on gravity. If a trauma patient is lying flat, supine on a backboard, the physics of fluids and gases change. The free air from a pneumothorax will rise and spread out evenly across the entire anterior chest wall. The heavy blood from a hemothorax will settle and layer out evenly across the entire posterior chest wall. On a flat, supine X-ray, you won't see a distinct line. You will only see a vague, generalized haziness that is incredibly easy to miss or dismiss as poor film quality.
You need gravity to do the sorting for you. When you stand the patient upright, the lighter free air immediately rushes to the very apex, the top of the lung, making the collapsed lung margin highly visible. And the heavy blood drops down to the bases, the costophrenic angles, creating a stark, horizontal, visible fluid level. Gravity is your diagnostic partner.
Briefly touching on the very end of the chapter material, foreign body obstruction. We've spent the hour talking about sharp things penetrating through the protective skin, but objects also get wedged, stuck, and lost inside the body's natural orifices.
Right. Otic and nasal foreign bodies, beads in the ear, beans in the nose, are incredibly common pediatric presentations. You can certainly attempt removal in the urgent care setting if you have excellent lighting, specialized tools like alligator forceps or a shook-necked catheter, a cooperative patient, and the object is very superficial and clearly visible.
However, the chapter provides clear boundaries on your scope. If the object is deep, firmly lodged, or if the child is highly combative, or if you're dealing with retained rectal or vaginal foreign bodies, you must refer the patient to the emergency department or a specialist. The risk of accidentally pushing the object deeper, causing severe mucosal tearing, massive hemorrhage, or triggering a deep systemic pelvic infection from retained, contaminated material is simply too high to manage safely in a standard primary care setting without conscious sedation or surgical backup. Know your limits.
So, synthesizing everything we've just discussed, for the NP student listening right now, what is the ultimate overarching takeaway when dealing with a chest trauma patient who, on the surface, looks relatively stable initially?
The overarching lesson is that you must maintain an incredibly high index of suspicion. The statistics are humbling. They tell us that roughly 60% of all patients who sustain high-energy blunt chest trauma will eventually develop a pneumothorax or hemothorax. But it is not always instantaneous. Often, the excruciating pain from a broken collarbone or shattered ribs distracts both the patient and the provider, masking the subtle, creeping pulmonary symptoms. Or the patient is young, fit, and the respiratory system is compensating remarkably well in the first golden hour. You cannot let your guard down. You must trust your objective physical exam. If the breath sounds are absent, believe it. Trust the physics of the upright X-ray over the patient's initial deceptive, compensatory calm. The collapse can happen fast, and you have to be hunting for it before they crash.
We have covered an absolutely massive amount of clinical ground today. We started at the microscopic cellular phases of wound healing and the surprising fluid dynamics of tap water irrigation. We explored the complex, specific pharmacology of spider venoms and the deadly histamine cascades. We worked through the complex mathematics of burn resuscitation and the chemical neutralization of industrial acids. And we examined the unforgiving, claustrophobic physics of cranial and thoracic trauma.
It is an immense amount of dense information to synthesize. But I hope the pattern is clear. If you focus intensely on understanding the underlying anatomical mechanisms, the fundamental why and how tissues break and react, then the sprawling, complex management protocols suddenly make complete logical sense. They aren't just arbitrary lists to memorize, they are the natural interventions required to fix the broken physiology. And as a final, provocative thought to leave you with, something to mull over deeply as you prep for your clinical rotations. Consider the rapid future of this diagnostic field. We talk extensively today about relying on bulky X-ray machines to find retained glass or needing upright chest films to utilize gravity to diagnose a pneumothorax. But with the explosive rapid integration of point-of-care ultrasound or POCI-USES directly into the hands of urgent care providers, how might your standard physical exam radically evolve in the next 5 years? We are already seeing advanced providers use a handheld ultrasound probe to easily identify radiolucent foreign bodies, like wood splitters, that are invisible on X-ray, or to instantly, dynamically visualize the loss of lung sliding at the bedside to diagnose a tension pneumothorax in seconds without ever moving the patient to radiology. POCI-USES is going to fundamentally revolutionize how you assess these exact injuries. It is a vital skill set to start researching and demanding in your training right now.
That is a brilliant, forward-looking point to end on. The technology and the tools will constantly evolve, but the foundational need for sharp, physiological critical thinking remains absolute. Thank you so much for joining us for this deep dive. You are walking into a high-stakes, incredibly challenging clinical environment, but you now have the deep knowledge to navigate it. On behalf of the Last Minute Lecture team, thank you for your unwavering dedication to learning, to mastering this craft, and ultimately to your future patients. Because as we said at the very beginning, when you step onto that clinic floor, the machines won't always give you a clean binary answer. You are stepping into diagnostic muddy waters, playing minesweepers every single shift. But with this understanding of pathophysiology, you are ready to figure it out safely. Keep studying hard, trust your exam, and we will see you next time.